So today we will be discussing a topic on ventilator graphics.
Yes, I see what brain knows. So this session targets to improve the eyesight or the interpretation of what we see on the monitor, which is available on our modern ventilators. This is a prototype screen, what you will be expected to see on your ventilator screen, a bit of lines, graphs, what we call it as scalars and loops in the middle in this particular model, of course. You can see the pressure plotted against time, which is one of the scalars, flow plotted against time, and volume plotted against time. Of course, you can see what are your set parameters on this side and which mode you have kept. All these are important for interpreting what is given in the middle part of the screen. So here you can find what rate we have set. We have set pressure control over there. We have set PEEP, oxygen percentage. And of course, you can go to advanced settings also. And most of the residents forget to document what is actually monitored. Along with set parameters, the one you see on this side of the screen, the monitored parameters is also important. Unless you document what minute ventilation the patient was on while interpreting a particular PCO2 value in your ABG report, how are you going to correct it? Whether somebody has corrected even before you came to see. So documentation of the set parameters and monitored parameters are important. Ultimately, we are not treating the monitors, we are going to treat the patients. Most of the modern ventilators give further details like compliance, P-plateau, expiratory flow, inspiratory flow, a lot of things, static compliance. So the graphic interface has become so much of advanced kind of thing that it actually intends to help in better healthcare delivery. But to satisfy that, the provider, the person, the healthcare provider near the ventilator should know how to interpret or make sense out of this screen, out of these graphics, out of the scalars and loops. That's what we are trying to explain in simpler terms in this session. So we will start with the scalars.
So today we are going to discuss an important topic. Dr. Saneesh has already introduced the topic, the interpretation of ventilator graphics. So in the initial part, we will be just going through the basics. So as already mentioned, we have scalars and the loops. In the scalars, what you have to understand is, here you can see the pressure, the flow and the volume. These are the plotted against the time. And again, you should always keep in mind, as is already mentioned, depending on the mode what you are keeping, your scalars also will change. So before interpreting these parameters, you should assess the patient and also to see like what are the settings you have kept. So we have the pressure scalar, pressure time scalar here. We have the flow time scalars here, and we have the volume time scalars also here. So as I've already told, the ventilators measure the airway pressure and the airway the flow, and we have different the patterns of waves as well. And we can see the square wave pattern here, the ramp pattern, like how fast the inspiratory flow is increasing. So that is meant by the ramp pattern. So we have different parameters like that, and we have an inspiratory and expiratory part as well. And as you can see, there is an active inspiration and there is a passive expiration. And here the expiration depends on the airway resistance and also the elastic recoil of the lung. and obviously the expiratory effort is also contributed at this part. So these are the parameters which is determining the different aspects. So as we have already discussed, we have this flow, volume, and pressure. These are plotted against the time. So one thing, you can put these three scalars in one side, and in the other side there is an option to make the screen split. I'm talking about the graphical part. And in the other side we can put a loops as well. Either we can go for a PV loop or like a flow volume loop as well. And on the other side, we should keep all the parameters here, the measured parameters. So in the measured parameters also, depending on the situation, you can go with the basic parameters like you can see here, the tidal volume, the respiratory rate, the FiO2, the minute ventilation, etc. So that may not be enough when you are treating a complicated patient, or when the patient's lung status is not that good. You may require additional parameters like plateau pressure, driving pressure, and again the compliance, etc., especially the static compliance. So you have to put another screen representing all these parameters. That is how we set the screen to look at these ventilator graphics. So now coming to the first, the scalar, that is the flow time scalar. So before that, we should understand the basic concept. So the flow is the volume divided by the time, or other words, the volume will be equal to the flow times the how much time you are keeping the flow. Now coming to the spontaneous breath versus the mechanical breath. So here you can see we have an inspiration and an exhalation. So this is the flow time scalar. So here you can see the flow, there is always a positive deflection or a positive flow during inspiration, and there is a like the passive part of exhalation. So that will be a negative deflection. This is as far as the spontaneous breath is concerned. But in case of a mechanical breath, here again we have a positive the deflection or a positive flow in the inspiration, followed by an expiratory phase. So the expiratory phase in in flow time scalar, whether it is a mechanical breath or a spontaneous breath, doesn't differ much. Only the values may be slightly different, but the flow pattern is almost same. You cannot differentiate whether it is a mechanical or a spontaneous looking at this expiratory part. But see, look at the inspiratory part. So the inspiratory part, the flow pattern is different in a spontaneously breathing and in a like a mechanically ventilated patient. So now we have to understand what is trigger. The inspiration is started from one point. So we have to we should have a trigger at this point. So what is the trigger means? Here the inspirator, the machine should detect that the patient is taking an inspiratory effort, and the inspiratory valve should open and there should be a flow. So this is the trigger point. And the trigger can be basically two types. You can have a pressure trigger and you can have a flow trigger. So after the trigger, we will be having the limit. So the how much flow is there, that is actually limited at one point. That can be either like a pressure limited or it can be volume limited, depending on whether it is a pressure control or a volume control. So from the inspiration, it is limited. Then the inspiration is cycled to the expiratory part. So this is the term called cycling. That is the one which determines at what point the inspiration has to go to the next phase of expiration. So then, so we have the cycle, then we have the peak expiratory flow rate in the expiratory part. So how much maximum flow the patient is achieving. Then we have different aspects of these flow time scalar. So like what is the difference when we observe in a diseased airway? See here, we have a normal airway, as you can see here. There is a like a positive flow, then there is a passive exhalation. Suppose if there is an obstruction, the obstruction is usually happening to the expiratory flow limitation. So the expiration will become prolonged. So here you can see this is the dotted one is a normal expiration. So that will take more time to touch the baseline if there is a airway obstruction or an expiratory flow limitation. So here one more thing you have to keep in mind. So here touching the baseline is the one which we are talking about in terms of a ventilatory graphics. But in actual what is happening? So suppose if you are pushing air into an airway, if there is an expiratory flow limitation, so the air to come out will take more time. So in between, if you are again giving a breath, the alveoli will not be completely emptied, and there can be something called an auto peak or an air trap. So this is the basic mechanism. The same way in active exhalation, you can see the patient is actively exhaling. So the emptying will happen fast, or it will touch the baseline faster than the normal way. So this is the obstruction and this is the active exhalation. So you should always keep in mind what is happening in the obstruction. So now coming to the air trapping or auto peak. So here I can again, I've already told, like during the inspiration, there is an expiratory, after that there is an expiratory flow limitation. So in this expiratory flow limitation, before like this alveoli are completely emptied, we are again giving one more breath. So the air will get trapped to the alveoli. So if you have like repeated such episodes, there will be more and more air get trapped inside the alveoli. So the alveoli will get distended. Intrathoracic pressure will increase. So what will happen if intrathoracic pressure will increase? Definitely your venous return will reduce. So that will again lead on to the circulatory collapse. That is one part as far as the hemodynamics are concerned. What is the other issue? You can see, like, because of the air trapping, there is already, you can see this expiratory part is deflected down. So suppose if the patient want to breathe over this thing, if you are triggering, you need more negative pressure. So this is already in the negative side. So if you want to trigger, you need more negative pressure or more effort is required. So there comes the concept of like an external peak, which we'll come to that later. Over to Dr. Saneesh.
So you can see here again, you can see the inspiratory part and the exhalation, which is passive. And here you can note that the exhalation curve goes ahead of the baseline, and next inspiration happens here only. So what does this area indicate? Basically, it indicates a leak in the circuit. So when you look at the screen, look at the flow time scalar. If you find this, you have to check for leak in your circuit. Maybe your cuff is not inflated properly, or your connections, you need to make sure it's push and twist, or check all the connections where your breathing circuit accessories are joining. Okay, this is not the only indication. This will be evident in your volume time scalars as well. So we'll move on to the pressure versus time scalar. So this is the scalar, the graphic you expect in a normal spontaneous breathing. So just a reminder, spontaneous breathing, like you and I are breathing, this is a negative pressure breathing. But what happens with mechanical ventilation? We are going to a positive pressure breathing. Here you can see that the pressure tracing goes to the negative deflection first for the inspiration part, and positive deflection to the exhalation part. So this is the pressure time scalar for a volume controlled breath. So I have given the complete screen on left hand side. On right hand side, this is what we are going to concentrate on. So here we are going to try and define what a breath cycle is, and then try to interpret the other dimensions and meanings. So, and a breathing cycle comprises of a phase of inspiration and then exhalation. One set of inspiration plus exhalation constitutes one breath cycle. Here you can see the airway pressure measured is plotted in the y-axis, and time is plotted in the x-axis in seconds. So the trigger, as Dr. Anoop mentioned, trigger is what starts the breathing cycle. So from trigger until this vertical line, that is the end of inspiration or the beginning of expiration, that we call it a cycle. Okay. So from the time of onset or trigger to the time of starting of exhalation is the inspiratory time. And from this time to the beginning of next inspiration is the expiratory time. I think this part is clear. So in a volume control breath, this is the typical shape of the pressure versus time scalar. Here also you can appreciate it. Okay, the upgoing part is inspiration, because the constant flow, this is a square wave pattern flow, is pushing in flow, and as time accumulates, the volume accumulates inside the lung units and the pressure builds up in this manner. This is the typical shape. So now you know what is trigger, what is cycle, what is inspiratory time, exhalation time. And now I hope you have noted that the baseline is slightly above the zero pressure. Okay, that is simply what we call as positive end expiratory pressure. And the highest point of peak airway pressure attained at the end of inspiration is the peak inspiratory pressure. Some of the ventilators mention as peak pressure. So P peak or peak inspiratory pressure, PIP. So that much is clear. Now, what I am going to do is I want to measure the pressure at the distal alveoli, but my pressure transducer is only at the airway. So what I do is I give an inspiratory pause before exhalation valve opens. So now the curve takes a new shape, because when the inspiratory pause starts, the peak inspiratory pressure, from the value of peak inspiratory pressure, the airway pressure drops a little bit, then attains a plateau, and then when the exhalation valve opens, proceeds to the exhalation. So I would like to request all the residents in anesthesiology, juniors, to concentrate on this point. So the highest value attained in this pressure tracing is still called pressure peak or peak inspiratory pressure. And now during the pause, it drops and attains a plateau, and that plateaued value, we call it as plateau pressure. What is the significance? Plateau pressure is a no flow scenario where whatever you measure at the airway is supposed to be equilibrated with the distal alveolar unit. So when you want to check for the alveolar pressure, or you are concerned about barotrauma, your concern is plateau pressure. So here there will be a pantelift of air between low compliance and high compliance lung units. Eventually there will be equilibrating. And remember, when there is a difference in pressure, there will be a flow. And when there is no pressure difference, no flow occurs. That means either end, the pressures are equal. So you got the idea? At the end of inspiration, give an inspiratory pause, your peak pressure suddenly drops and maintains or attains a plateau value, which is actually reflecting the pressure exerted at the distal lung units, which we are concerned when we are speaking about lung protective ventilation or volutrauma, things like that. And then you open the exhalation valve, allow the exhalation to continue passively. So now you look at this tracing again, and the difference between pressure peak and the plateau pressure is reflecting the pressure required to overcome the airway resistance. Okay, so this work done, this area represents trans airway resistance. And this area in white represents trans thoracic resistance. Okay, I hope this is clear, because when we are speaking about, say, acute severe asthma or severe bronchospasm, the airway resistance is high. So you anticipate that pressure peak might go up. Still, if your plateau pressure is acceptable within limits, you are still not worried about barotrauma. Similarly, we'll come to that graphic later. Yes, this is the graphic. Anoop, if you want to chip in, you can join. So first one is the normal tracing, pressure versus time. This is the peak inspiratory pressure and the plateau pressure we have just mentioned. And please focus on this red line. Okay, fine. In next scenario, you can find the plateau pressure remains normal within the acceptable range. Only the peak inspiratory pressure goes up. That means the work done against the airway resistance is high. So this is a case of high airway resistance. Okay. Now, when the flows are high, also the airway resistance will be more, because the more flow you push through the same caliber airways, the peak pressure generated will go up. Still, the plateau pressure will remain the same. And now look at this curve where plateau pressure itself is high. The peak pressure, the difference between peak pressure and the plateau pressure is almost near normal. An example of this curve you will be getting will be ARDS. ARDS, when the lungs are supposed to be very stiff. So your plateau pressure will go up because we need to overcome this elastic recoil of the lung, because lung units have become stiff. So low compliance, you can see the curve, the red line curve is more steeper. When it goes steeper on the plateau pressure goes up from your normal values, then you need to think about something that has caused the lung to be stiff. It could be a pneumothorax. It could be an ARDS. Okay. But if your plateau pressure is normal and the peak pressure only is going up, it could be an acute bronchospasm. It could be a kink in your breathing tubes. It could be secretion blocking your airway or the endotracheal tube. So your troubleshooting differs depending on which kind of scenario you get in this combination of peak pressure and the plateau pressure. Anoop, you want to add anything on this?
Yeah, here the main thing, as we have told, there are two concepts when the pressures are increasing. Either it can be because of a resistance, or it can be because of the stiffness in the lung, or in other words, we call it as a compliance. So a less compliant means usually something like an ARDS lung. It can be because of other reasons also, like a fibrotic lung, or a patient, the lung become stiff because of pulmonary edema. So you can have different situations, or like because of pneumonia, all those things. So whenever the lung parenchymas are involved, or the lung will get more stiffer. And when there is an airway resistance, like in obstruction or other situations, as he has mentioned, definitely your the peak pressures will be going high. So there are two types of lung. One thing with an obstructive airway disease like pathology, or we have something like an ARDS disease like pathology. And obviously we have something a normal lung. So we will be having usually these three scenarios whenever we are coming across a mechanical ventilation. We can either have a normal patient, like you are ventilating a patient for muscle paralysis, or you are ventilating a patient for a CNS reason where the patient is having a low sensorium. So these situations, like you will be having absolutely normal lung with normal compliance and normal airway pressures. At the same time, if you are ventilating a COPD or an asthma patients, you will be having a normal compliance where the lung distensibility will be normal, but at the same time, you will be having an increased resistance. So here, your strategy will be different. And we have another the complicated thing called a lung getting stiffer. The compliance will be more. So we should know how to increase the compliance, and how, by increasing the compliance, how we can improve the oxygenation, and how we'll assess the oxygenation by looking at the PF ratio. So the how we can improve the PF ratio. So these three scenarios also are important, and the ventilator graphics has also a role in adjusting these parameters to the optimal level. I've already told, by looking at these parameters, we should be able to identify the pathology. Once it is identified, By looking at these parameters or by utilizing these parameters, we will be able to set the ventilator optimally.
Yeah, again, that graphics will give you a reassuring change in the graphics when your bronchodilator works, because the difference between peak inspiratory and plateau pressure narrows. That means your troubleshooting is actually working. Okay, so this is another comparison between a spontaneous breath and mechanical breath. Okay, one is negative pressure breath, the second half is positive pressure breath. So now, this is what we have described as controlled or mandatory breaths, where the machine starts the breath. The trigger is by the machine, maybe time triggered breath. It goes, and during the cycling, it goes to the exhalation phase. But look at the curve on the left-hand side, because it starts with a negative deflection on the pressure time graph, and then it proceeds to something like machine controlled breath. Or this is a prototype assisted breath, where actually the trigger, what starts a breath, is by the patient. So you look for this small curve which draws the pressure tracing below the baseline. That means it is the trigger from the patient end. Anoop?
Yeah, this is a very important slide as far as we are understanding the different modes. So we know that there is something called a control mode and there is something called an assist control mode. So majority of the time we get confused between a control mode and an assist control mode. So the first thing what you have to understand is, in present day ventilators, in none of the ventilators, we don't have a control mode. So whatever mode we are having in our present day ventilators, whether it is an ACV, PCV or BiPAP, whichever name you call, all those modes are assist control mode. How we can make out, so whether that mode is having a trigger sensitivity. So if there is a trigger sensitivity associated with that mode, it is an assist control mode. And in control mode, there is nothing like a triggering, and there is no coordination between the patient effort and the machine given breath. So at a fixed time intervals, the machine will deliver the breath. So you will be having only the older anesthesia ventilators with this control mode. All the ICU ventilators are having only assist control mode. So that concept should be very, very clear. Then what is the difference between these two? Or if patient is not breathing, that is the one which you have to understand. If the patient is breathing, so that we can that synchronization we can fine tune by adjusting the trigger sensitivity, and the patient effort should be sensed by the machine and the machine should deliver the breath. In assist control mode or in the control mode, you can see the tidal volume or the pressure will be constant depending on the volume control or pressure control breath. So the volume will be the same, but the difference is one thing is triggered by the patient, other is triggered by the machine alone. But here in assist control mode also, if the patient is not triggering, the machine will take over that. Suppose if you are keeping a rate of say 60. So every 1 minute, the machine will trigger one breath, even if the patient is not taking that much breath. At the same time, if the patient is also taking 60, each will be coordinated with the patient effort. So this is the difference between an assist control breath or assist control mode or a control mode. Same thing is applicable here, assisted breath and a controlled or mandatory breath. So this concept should be very clear in understanding the different modes of ventilation.
Now we go to the third type of scalar, volume versus time. Okay. Volume, is it measured by the ventilator? No. Ventilator measures only the flow. And flow into time is displayed or interpreted as volume. Clear? So ventilator doesn't measure volume. So it measures flow, multiplies it by time, and gives you the volume. Again, back to basics. This is the volume delivered during inspiration. So the volume is on the positive side. Remember, there is no negative marking in the volume side because it starts from baseline 0 and then after the cycling exhalation phase, this is how the exhalation curve looks like. So the peak value, the highest value corresponds to the inspiratory tidal volume. And the time for inspiration is Ti, or inspiratory time. Time for exhalation is Te. Okay, now how it is going to help you? When you look at the volume versus time, if you find the exhalation curve is not touching the baseline and suddenly drops with a vertical line and proceeds to the next breath cycle, what does it indicate? That indicates air leak. I've already mentioned how it looks like in a flow time scalar. Okay, so this indicates leak in the circuit. Go look, check your cuff pressures, check your connections, and try to see whether you can bring it down to a scenario where this tracing touches the baseline. And this is another thing, just now I mentioned we don't have negative values, but here the exhalation is proceeding on to the negative side of the scalar. What does it indicate? It indicates active exhalation. Again, you need to make the patient passive to avoid this active exhalation. Making the patient passive should not be equated to muscle relaxants. Even deeper level of sedation can also be a good solution in case of such dysynchrony.
And one more point in that leak, the practical point. So, like we are using HME filters nowadays, and the majority of the time when we monitor the end-tidal carbon dioxide, we have two types. One is a like mainstream monitor and a like a side stream. So the side stream, the carbon dioxide, we will be taking mainly from the leak port in the HME filter. So if you keep that HME filter open, you will be having the leak. So that is a common mistake all the respiratory therapists or the bedside nurse usually commit. So after removing your EtCO2 line, there is a cork. If you have to put it properly. If you are not putting it properly, your measured tidal volume will be less. And again, you can see here in the graph also, you can see the leak. The same way, if a patient is developing an airway obstruction, your peak pressures are going high. Say your peak pressure is 45. And your usually the cuff pressure, we keep it somewhere around 25 to 30 because that is the pressure which is slightly less than the capillary pressures in the trachea. If you keep more pressure, the tracheal blood flow can get impaired and there can be the tracheal damage. So if the peak pressures are going high, even if you keep the cuff pressure at 30, if your peak pressures are say 40, 45, you can have a leak around the cuff. So that is the one situation where you can have a leak. So even if you are even after keeping a proper cuff pressure and all the circuits are intact, including your your HME filter, then you have to think about the other possibility also. Look at the peak pressure. If the peak pressure is too high, then that may be the reason for causing the leak. And if that leak is significant, maybe for a shorter while until this spasm is getting settled, you may have to keep the cuff pressure slightly on the higher side, or you will have to definitely accept the leak. So those two practical points you have to always keep in mind as far as the air leak is concerned.
Okay, now that we have played around with the pressure, volume, and flow, now we will go into loops, which will enlighten us on the interplay between pressure versus volume, flow versus volume, or pressure versus flow. Anoop, you will take the first part.
This is a very important the part of graphics again. The pressure volume loop, or the commonly called the PV loop. So here in PV loop also, as you can see, you have different types of breath. The first one, as you can see, is a controlled breath. Then we have an assisted breath. How will you make out? Here there is a patient trigger here, and there is a spontaneous breath. So here in spontaneous breath, you can see, you should always see the difference. So the first part of this limb, that is the inspiratory part, I. Then there is an expiratory part. So here both in controlled and the assisted breath, you can see that there is an inspiratory limb and there is an expiratory limb. But look at the spontaneous breath. So there is an inspiratory limb which is a negative pressure, and there is a expiratory limb which is positive. So it is completely opposite of the assisted breath or the controlled breath. So this is the main difference in PV loop between the mechanical breath and the spontaneous breath. So here you can see this inspiration is in this direction followed by the expiration. Here this inspiration is like this and there is an expiration. And you have to look at different aspects in a PV loop, which will come to that later. Like inspiratory limb, what all things we have to look, expiratory limb, what all things we have to look, the curve as such, what are the points to be considered. See the components of PV loop. So this is actually I've already told. So we have an inspiratory part here, then followed by an expiratory part. So this is the inspiratory part, and this is the expiratory part. And you have if it is this is the peak inspiratory pressure, and here this is the volume here. So this is the volume part, and this is the pressure part. So what will happen if the airway pressures are going high? The curve will lean towards the pressure part. Okay, or if suppose if there is the volume is decreasing because of the resistance, etc., it will move towards this side. Okay, so that is the basic thing about the PV loop. So now coming to the other aspects of the PV loop again, you can see here. See, this is the normal PV loop. We have an inspiration and an expiration, as we have already told. The upper part corresponds to the tidal volume, and we have a inspiratory, the peak pressures as well. So here, what is the difference? We are applying a PEEP here, positive end expiratory pressure, so that there will be always a pressure inside the alveoli, or we are applying the pressure to keep the alveoli open. So once you apply the pressure and keep the alveoli open, what you are expecting? Your compliance should improve. So we should, in the coming slide, we'll explain how the compliance can be interpreted by looking at the PV loop. So here, if there is a PEEP applied, your PV loop will be starting from the pressure, from the how much PEEP you are starting. You are applying here. Otherwise, it will be starting from the 0. If there is a PEEP, that will be starting from that point. Suppose if you are keeping a PEEP of say 10, so it will be starting from that 10. So if it is not starting from the baseline point here, that means you are applying an external pressure at that point. So now we see the PEEP once it is applied, what difference it is going to make. I've already told there is an inspiratory limb, expiratory limb, the tidal volume, the inspiratory pressure here, and we are applying the PEEP. So what about the work of breathing? So we have the curve has two parts here. Like if you draw a line in the middle of this PV loop, we have a part A which is shown in the pink and part B which is showing in the violet color. So the pink part is basically the inspiratory part, and the violet part is basically the expiratory part. And this part indicates the resistive work, and the other part indicates the elastic work. Okay, so whatever change is happening in the compliance or the resistance, that will be reflected in the resistive work. Okay, or whatever changes is happening in the expiratory part, or that will be indicated in the resistive work. Okay, so that is the elastic work and resistive work in the PV loop. And we have inflection points. We have a upper inflection point and a lower inflection point. The lower inflection point is the point you can see where the curvature started increasing in the inspiratory limb. So this is the lower inflection point. The same way in the expiratory limb, where the curvature started increasing the angulation, that is the upper inflection point. So we have a lower inflection point and an upper inflection point, and based on these things, initially there were many equations and tools to determine the adequate PEEP. But again, this is not very practical aspects. So by looking at only one PEEP, you cannot look at an upper inflection point and lower inflection point and decide what is an adequate PEEP. So PEEP titration using a PV tool does not limited to a single PEEP. So we need a different PEEP on an incremental or a decremental basis. Then you have to plot different PV loops. Then we have to see what is the difference happening to the upper inflection point and a lower inflection point. That we can do it in many ways. Either we can gradually increase the PEEP and see and take different PV loops and see the changes, or there are PV loop titration tools like in Hamilton ventilators and all. We can set it from what PEEP the recruitment has to start. So whatever the PEEP increment we are giving, we call it as a recruitment. So that after giving that PEEP, at what PEEP you have to keep, or how much level of PEEP you have to keep also, that we have to determine depending on these tools. So here you just understand there is something called a lower inflection point in the inspiratory limb and an upper inflection point in the expiratory limb. So now we'll see how clinically we are going to utilize these part. So here, as I've already told, this is a what type of breath it is. This is an assist controlled breath where you can see a patient triggering is happening. So the patient is triggering followed by an inspiratory flow, or the volume is getting generated here. If there is the trigger is not adequate, the patient will have to generate more energy to make a trigger, or more the negative pressure has to be created to make the ventilator sense that breath and trigger a breath. So that will lead on to increased work of breathing. So you should titrate the sensitivity or the trigger in such a way that each respiratory effort should be sensed by the machine and an inspiratory flow is happening. At the same time, the minor fluctuations in the circuit, like if there is a like too much secretions in the circuit, a movement in the circuit can also have a slight flow or a pressure difference. That should not be sensed by the machine and should not be delivered. If that is happening, that will happen auto triggering. So while adjusting the trigger sensitivity, it should be in such a way that auto triggering should not happen. At the same time, all the patient's effort should be sensed properly and the breath should be delivered. Clear? Auto triggering should be prevented and the patient effort should be entertained. And there is always a misconception. I've seen many persons doing that. Like suppose if the patient is becoming too much tachypnic in a ICU, that can be many reasons for that. If the patient is febrile, or if the patient is having very bad lung, or if the patient is having sepsis, or if the patient is too much agitated, or your sedation is not proper, the patient can have a tachypnea. So you should never try to control the tachypnea by controlling the trigger. I've seen like, so suppose if the patient is comfortable at 2 trigger, you make it a 5 or 10 to reduce the respiratory rate. Never do that. What is going to happen? It is just like choking your patient. So you are giving more trigger, the patient has to generate more work of breathing. Definitely the muscle will get exhausted fast, and nothing will happen to your respiratory rate. Even if it respiratory rate is coming, that is by increasing the work of breathing. So never try to adjust the respiratory rate by adjusting the trigger. That is a basic concept. Okay. So now in the PV loop, we have already told different ways to detect the air leak. Here again, so after the air leak, you can see the volume, the part, it will not touch the zero pressure. So here there is an air leak. So this is how you make out the air leak in the PV loop. Okay. Now, what is an inadequate inspiratory flow? This is also very important. You can see this is a normal one, and when there is an inappropriate inspiratory flow, I've already told that you can see a deflection in the inspiratory part. So if the inspiratory part is you can see the upper part should be a concave. If the concavity is getting lost towards the convexity, that means the inspiratory flow is limited. The same thing can happen if there is a compliance is also limited, and we'll come to that later. So, but the reason may be inappropriate flow, or if the patient is having an active inspiratory efforts during the same inspiratory phase again, that can also be shown as a deflection here. So this is an active inspiratory effort and this is an inappropriate flow. And this is also like an important practical point. If there is an inappropriate flow, in majority of the present day ventilators, you don't have an option to increase the flow. So what we can do? So you reduce the inspiratory time. So once you reduce the inspiratory time, definitely your flow will be more. So that is how you can adjust this inappropriate flow. Now, what is happening to the increased airway resistance? I've already told you have a normal slope here, but if there is a airway resistance is increased, the slope is actually lower down here. So here you can see the outside the concavity will increase here. So this is because of higher trans airway pressure. So in a PV loop, if the trans airway pressure or the resistance is increasing, you can see the inspiratory part will be pushed down. So that indicates there is an increased airway pressure. This is a very, very important slide as far as the PV loop and the ARDS ventilation is concerned. You can see the green one, which is a normal compliance length. You can see the inspiratory part and expiratory part. If the compliance is improved, what will happen? So, and there are two types of PV loops here. You see, this is a volume targeted ventilation. You can see the volume is always kept constant. Depending on the compliance, your airway pressure will be vary. You can see like a normal compliance, the airway pressures is here. If the compliance is decreasing, that is the pink part, your tidal volume will be same, but you will be giving more pressure, or for the same tidal volume, more pressure will be generated. If the compliance is improving, it is again shifted towards this line, and again your pressure will be reducing. So how you are clinically or practically going to utilize that? Suppose after applying the PEEP, whether the patient is having a better compliance or better oxygenation. You look at two things. You can look at either compliance or look at oxygenation. These are the two ways by which you see whether the recruitment is working properly, or you are recruiting more and more alveoli. So if the curve is shifted towards this axis, that means your PEEP is working and you are recruiting. At the same time, if it is like after increasing the PEEP, if it is like shifted towards this side, that indicates the PP, the compliance is decreasing, or you should not increase the PEEP that much. Okay, so that is how you utilize the PEEP to titrate, looking at the compliance or by looking at the PV tools and assessing the compliance. This is for the volume targeted ventilation. See what is happening to a pressure targeted ventilation here. So here you can see the different changes here. Here again we can have this is a pressure targeted ventilation where the pressure is always constant, but here the upper part, the volume will be vary. So the green one will be the normal compliant length. Suppose if the compliance is increasing, it is again shifted towards this side, but see the tidal volume is increasing, but the pressure is kept constant. If the compliance is decreasing, it is shifted down, but again your pressure is constant, but the tidal volume will be reducing. So the PV loop, even in compliance change, you can have two types of PV loop changes, one in pressure control ventilation and one in the volume control ventilation. So your aim of increasing the PEEP is improving the compliance. That will definitely improve the oxygenation also. So you look at the SpO2 and look at the compliance, then decide whether to increase the PEEP or not. So if at one point of like a PEEP incremental level, suppose where you are increasing from 5 to 7, your compliance is improving, or SpO2 is better. 7 to 9, again it is improving. 9 to 10, it is improving. From 10 to 12, if you are improving and your SpO2 is coming down and compliance is coming down, that means you don't need that much PEEP. So 10 will be the optimum PEEP for that patient. Okay, I think you got it. So that is how you go with a incremental PEEP titration. The same way you can go with a decremental PEEP titration also. Like after recruiting, say from 15 peep, you can come down by 2, etc. 15 to 13, your compliance is almost same. From 13 to say 12, it's same. After 10, the compliance is improving. So the 10 will be the best peep or the optimum peep. Okay.
Now we'll combine another two parameters, flow against volume. Here you can find flow on the y-axis. Definitely there is a positive side and a negative side. Okay, you can see the typical shape of inspiration starting from 0. Flow is going up and then it is reaching a particular point, that is our until our tidal volume, that is where it touches the x-axis is the tidal volume delivered. Then the passive process happens. The reverse direction flow is indicated in the negative side of the plot, and you can see the exhalation part. Again, you can find the lowest flow rate marked on the y-axis will be the peak expiratory flow rate. Fine. Now, once you see a shape like this, of course, we have a normal curve to compare for teaching purpose, but actually in real life scenario, you may not get this baseline value. Okay, here what we can see is there is a scooped out pattern in the expiratory curve. And you can also note that the PEFR, peak expiratory flow rate, the value has come down. What does it indicate? That means there is expiratory flow limitation, which happens with increased airway resistance conditions, like say acute exacerbation of bronchial asthma or COPD. Now we can see you get this flow volume loop on your screen. Look at the Scalars side. What do you find there? You can, again, there is a normal plot given for your easy understanding. In the acute bronchospasm phase, the phase B, you can find the peak pressures going up. Okay. Look at the bottom part. Volume maybe delivered will be less. Look at the flow versus time. You can find that the exhalation part is not touching the baseline by the time the next cycle starts. This is exactly what we call as auto peep or intrinsic peep or air trapping. So all these can be seen together in case of acute bronchospasm or increased airway resistance. Your peak pressures go up. I never told that plateau pressure goes up, right? Okay, plateau pressure, as you can see here, is remaining the same. So alveolar end, nothing happened so far in this particular case. Okay, so, but the peak pressures have gone up because the trans airway pressure has gone up. So the flow has to do work against an increased airway resistance. You can appreciate the intrinsic peep. And the point we are discussing is flow volume loop, where you can see a typical scooped out pattern in the expiratory curve part of the loop and reduced peak expiratory flow rate. So now you give some bronchodilation or remove the trigger by giving an analgesics or something, or if it's an endobronchial tube migration, pull out the tube. Immediately you will find that the peak pressures are coming back to the normal. The expiratory flow curve is beginning to touch the baseline once again. And of course, the volume delivered may improve depending on what was the impact before that. So again, the graphics will help you to identify things, institute your corrective measures, and see in front of your eyes what changes are reverting back to the normalcy or baseline. Okay. Here again, you can have a flow volume loop. You can find the inspiration and exhalation. The black one is normal. Here comes the abnormal one. So what is the problem here? Okay, the expiratory part of the loop is not returning to the baseline. Hope you got it. It is nothing but air trapping or auto peep generation. Next scenario, again, you have the baseline. Yeah, here it touches the baseline much beyond the zero volume. Okay, so it's happening much beyond the expected in the x-axis, in the positive side of the x-axis. So what's happening? The patient, the circuit is having air leak. That's why the inspiratory volume is not fully exhaled or it's escaping somewhere.
In this flow volume loop, like as you can see, don't get confused between air leak and auto peak. Like in air leak, this will touch the baseline early, but in the other one, it will not touch the baseline and it will be touching here. So the auto peep and the air leak, it is a bit confusing in this flow volume loop, but it's very easy to understand as well. So always keep in mind, if it is touching here, it is auto peak. If it is touching early, that means there is an air leak.
Okay. So we'll revise with the other flow versus time scalars also. You can see how the flow versus time scalar look like on the top left half, and the top right, you can see what happens to the volume versus time scalar. So now this is how you collect all the information and make sense out of it. So the next scenario, this is very familiar to all of us, because day in and out we'll come across this scenario where the exhalation part gives this particular appearance, slurred appearance, and goes and touches the baseline. This is when your circuit is filled with the airway secretions or water. So there will be oscillatory movements during the passive exhalatory flow. So the curve typically looks like this. So what do? You clear your circuit or do ET suction, remove the secretions, and then see what is the change in the loop. Now I think we'll put things together in different modes of ventilation. What happens? Modes of ventilation generally are either spontaneous modes or mechanical modes. Mechanical mode, as you know, may be volume targeted or pressure targeted. So this is how you see the scalars on a spontaneous breath. Okay, spontaneous breath, inspiratory flow on the positive deflection, exhalation curve on the negative side. Pressure, as I mentioned, inspiration is negative pressure deflection. Exhalation is slightly positive towards the positive side. Volume curve has no negative side. It goes up and comes back. Clear? Keeping this in mind, we'll go to CPAP. Here we are plotting the flow time for the CPAP. Pressure versus time. Mind you, all the breath cycles are triggered by the patient. Okay. So now the question is, what is that CPAP level? CPAP level is continuous positive airway pressure level. That means we are actually raising the baseline to a given CPAP value, say, for example, 5 centimeters of water, and we are trying to maintain it throughout. Okay. And the patient is asked to generate or trigger the flow. And then you can see the slight negative deflection from the baseline, which is actually the trigger. And then the pressure builds up and then comes back to the normal, again, back to the baseline again. This is the volume delivered. And this is the flow pattern. Okay. So CPAP is basically when your baseline is elevated and patient starts breathing. Patient triggers and patient cycles the breath, and the rate and the volume, everything is determined by the patient. The only difference is we have changed the baseline from zero pressure to a CPAP, or continuous positive airway pressure level. And now pressure support ventilation. I know we would like to take this typical scalars in pressure support ventilation mode.
Here, the main difference between the CPAP and the pressure support is, this is again the patient triggered. You can see these all are patient triggered, or otherwise all these breaths are started by the patient. Then it is flow cycled and pressure limited mode. Here you can see that there is a flow cycling and the pressure is always constant. So one more thing you have to keep in mind is, like we told about an inspiratory pose to assess the plateau pressure. That is for the volume control. If it is a pressure control, you can see the upper part is always the plateau. The pressure pattern is like that in a pressure control mode. So whatever pressure control you are keeping, that will be the plateau pressure. You don't have to measure the plateau pressure there, or whatever PP you getting, that will be same as plateau pressure. Both will be same. So you don't have to put an inspiratory pose again, or like inspiratory hold again to measure the plateau pressure in a pressure controlled ventilation. So what is the difference between a CPAP and the pressure support? So here see, the volume generated in a CPAP will depend on patient effort only. There is no support for that volume generated. Suppose if the patient is generating only say 150 ml, that will be always 150, or if it has to be say 300, 400, the patient effort should be increased. In pressure support mode, we will give some support also here, say some 10 centimeter support to attain a tidal volume of 400. So the 400 tidal volume will be delivered. But what is the problem here compared to an assist control mode? Here, depending on the patient effort, if the patient effort is more, this may go up to 600 ml. Suppose the next breath the patient is generating a less effort, then it can go up to 200 ml. So your tidal volume will be varying depending on the patient effort, even if you are keeping a constant pressure support. That is the problem between the pressure support mode and the assist control mode. We'll explain that in later. So here it is almost like a CPAP, not CPAP. CPAP means you will have to give a PEEP also. Here we are doing without the PEEP. And along with the pressure support, if you give a PEEP here, the baseline will be deflected upwards or pushed upwards. So usually we will not keep a 0 PEEP and pressure support. We always keep a say minimum of 5 PEEP to keep these alveoli open or avoiding the de-recruitment. And the pressure support also we will not usually keep at 0. Even if you see like the extubation tolerance or the weaning trial when we do, at least 6 to 8 centimeters of water pressure support will keep. Why? Because for the patient to take the breath through the inspiratory leaf, there is a resistance required than the normal breath. So that has to be neutralized by giving an additional pressure support. So while putting the patient on CPAP with pressure support, don't keep the patient on 0 pressure support. You have to keep at least 6 to 10 depending on the patient status. Okay, then only you will be able to assess the patient tolerance. By keeping 0 pressure support, if the patient is getting exhausted or tachypneic, that doesn't mean it is failing. You have to keep somewhere around 6 to 8. Or there are newer modes, something like an automated tube compensation or ATC mode, where the machine itself will sense what is the resistance in the circuit depending on the tube size and the circuit, and the machine itself will offer a pressure support to neutralize that inspiratory resistance. Okay, that is about the pressure support mode.
This is the CPAP with the pressure support that we have just explained. So almost the same thing, but the baseline is elevated to a CPAP level. Anoop will explain about the flow cycling, also expiratory trigger sensitivity in this graph.
So here again, this is another concept which we have to understand. See, this is called the flow cycling or expiratory trigger sensitivity. I've already told there is an inspiration and the inspiration is changing to an expiration at one point. So how, if it is a spontaneously breathing patient, If it is a controlled breath or say like a assist controlled breath, machine will determine. Like you can set an IE ratio. Depending on that, you can decide at what point it has to be cut down. But if it is a spontaneously breathing, like in a CPAP mode, we don't have any control over IE ratio. So how you can control that? By setting the flow cycling, or it is called an expiratory trigger sensitivity. So this is usually applied in an NIV mode, not the other invasive mode. In invasive modes, also in spontaneous breath, you can do this flow cycling, but routinely done in the NIV mode. So in NIV mode, adjusting the IE ratio is based by looking at the expiratory trigger sensitivity or flow cycling. And here you can see again by applying the CPAP level, you are keeping the alveoli open always, or there is always a pressure in the alveoli, or the constant pressure is maintained in the system. Now we will move on to the next mode, which is called the control mode, which I've already told. There is nothing like a control mode in present day ICU ventilator, but you should understand what is a control mode. Like as we have already told, this is the flow, and you can see there is nothing like a negative deflection here. All the preset peak flow is happening. The pressure is also, you can see, it's always positive, and there is no trigger happening here. And depending on the compliance and airway resistance, the pressure will be varying depending on the set tidal volume, because it's a volume control ventilation. Suppose you are keeping a 400 tidal volume, the machine will give a 400 tidal volume, but the pressures will vary depending on the compliance. But here also you should keep one thing in mind. Suppose if you are ventilating a patient with severe bronchospasm, there is something called in alarm limit, there is something called the P max. Suppose if P max, if you are setting at 40, and if the airway pressures are shooting high, or if the airway pressures, if for a 400 ml tidal volume or a 350 ml tidal volume, if the airway pressures are going up to 55, this will, if you keep a Pmax at 30, it will limit at 30, and the tidal volume generated will be only 200 or 150. So what will be the ultimate effect? The patient will go into underventilation or hypoventilation, and again carbon dioxide buildup will happen. So you have to always set the Pmax according to the patient airway conditions, especially when ventilating like a COPD or an obstructive airway disease patient. I think you got that point. Okay. So now coming to this is the pressure control mode. Sorry, this is a volume control mode. And now we have the assisted mode. So assisted mode, what is the difference? Here again, you can see this is the spontaneous breaths here, and the tidal volume is constant because it's a volume targeted ventilation. But here again, what you have to understand, the tidal volume is always constant. It is preset. Suppose if it is a SIMV, even if it is triggering by the patient, and even if you have set a pressure support constant, but your tidal volume will be varying. But in the assist control mode, your tidal volume will be always constant in a volume control mode, or your pressure will be always constant in a pressure control mode. So that is the beauty of the assist control mode. So now we have the second one, that is the SIMV. So here in SIMV, what is happening? This is very, very important, and you should be very clear about the SIMV concept. So we are giving a mechanical breath. In between, there is a window where the patient is allowed to breathe, but there is no pressure support. Suppose, say, we have kept a pressure or is a volume targeted ventilation. So we will go with, we'll see the volume times scalar also. Suppose you have kept a tidal volume of, say, 500 ml. So in these two 500 ml is machine triggered breath. So in this, the window, the patient is taking spontaneous breath, but the patient may be generating only 100, 150, or even 200 or 50, depending on the patient effort. Then why this SIMV was introduced? So when SIMV was introduced, the concept was you are giving a machine breath. In between, the patient is allowed to take his own or her own breath. And the concept was during the spontaneous breath, the work of breathing will be less, or the diaphragmatic effort or the inspiratory muscle effort will be less, so that the patient will be getting a muscle rest during this spontaneous breath. So this was the concept when this SIMB was introduced. But later it was tested by looking at electromyogram tracing of diaphragmatic muscles and inspiratory muscles, and again the muscle energy consumption. And what was shown was the energy consumption or work of breathing was more during these spontaneous breaths. Okay, so there is no point in allowing the patient for the spontaneous breaths. Okay, you will not get any additional benefits of allowing the patient to breathe. So instead of that, if you put the patient on assist control breath, all these breath will be of same quantity, like, or the same volume, and the work of breathing also will be less. That is why the SIMV mode is completely outdated now, and SIMV mode is not used for ventilation or even for breathing. Now we have the control mode. I've already told. Here there is nothing like there is no space for patient triggering. All are machine triggered, and it is time cycle. So how much inspiratory expiratory time you are keeping, depending on that, it will be cycling. Okay, and here you can see the pressure is pressure control mode. The pressure is constant, and this is the plateau pressure also. Your tidal volume will be varying depending on the lung condition of the the patient's lung condition. Whereas in assist control mode, again the pressure targeted ventilation, as I've already told. See the flow pattern will be like this in the assist control mode, the pressure targeted, and it is time cycle. The inspiration and expiration is switching over based on the time what you are keeping, or the IE ratio what you are keeping, and the breath will be the triggered by the patient. But always keep in mind, don't get confused. This is, suppose if the patient is not triggering at this point, the machine will the trigger or shoot at the time what you have kept. Suppose if you are keeping a respiratory rate of 10, so you need one respiratory cycle will be 6 seconds. So every 6 seconds, one breath will be triggered, even if the patient is not taking a spontaneous breath. At the same time, if the patient is taking the spontaneous breath during that time, if the patient is taking 10 breath, all those 10 breaths will be synchronized with the machine breath. Machine will not give an extra breath. And at the same time, so everybody will think that the patient will be able to breathe only 10. No. If the patient is breathing, say, 20 times, all those 20 breaths will be supported at the set pressure control level by the machine. So the patient is allowed to breathe in assist control mode also, just like SIMB mode, but there is nothing like limited breath in 2 control mode. Every part of the respiratory cycle or the whole cycle, the patient is allowed to breathe, but the pressure or the volume, depending on the control what you are setting, it is always constant. It is not vary. Same way we have SIMB mode, pressure targeted. There is no difference, which we have already discussed. SIMB, just like the tidal volume, the pressure will be varying. The flow will be almost same, but you can see an inspiration and an expiration. And here in the pressure, you can see the pressure, the positive, but the spontaneous breath, the patient effort is less. The pressure generated will be less, and the volume will be different depending on the patient effort. But see, we are setting a pressure control here that is applicable only to the machine generated breath. The spontaneous breath, there is nothing to do with the pressure control. And if you want to improve the tidal volume here, spontaneous breath, what we have to do? We have to add the pressure support. So in the next slide, you can see SIMB pressure control with the pressure support. So here what will happen? You can see the spontaneous breath in between like the previous mode, but the difference will be, just watch this graph. This is the flow happening. So here you can see the flow is slightly more than the previous one. The pressure, you can see the pressure generated, look at this point here. This is the time cycle, and here the flow cycle. Here the pressure generated here, even though the patient is generating lesser pressure, you can give pressure support and increase the tidal volume. And this is the set pressure control. but here this is the set pressure support. This is the pressure control and this is the pressure support. Both are different in SIMB. But in assist control mode, your pressure control and the pressure support is same. And even if you set a pressure support level, depending on the patient effort, the tidal volume will be varying. So that is why you can see the tidal volume is fixed only for the machine assisted, machine controlled breath. Other breaths, the tidal volume will be varying depending on the patient effort. Okay, so that is the difference between assist control, the control, and the SIMB mode. This is same like the SIMB with the pressure support in the volume targeted ventilation, which we have already discussed. This is the pressure support level for the volume targeted ventilation. Now, along with that, if you apply a PEEP, so usually we will not keep a PEEP like that. We will have to always keep a pressure support also. Along with the pressure support and SIMB, we always keep a PEEP also. So when we apply a PEEP here, just like the CPAP in the initial mode, the baseline will be deflected upwards. So you always have a the pressure or the pressure is always maintained at the set PEEP level or CPAP level in the airways. So this is regarding the SIMB with pressure support along with the PEEP or CPAP. Okay, the PEEP and CPAP is usually interchangingly used. In majority of the practical purpose, CPAP is the one which we usually use for NIV, or we use the EPAP, or in the invasive ventilation we use the PEEP. So the PEEP, the EPAP, and the CPAP, the concepts are same.
I think here we can have the same thing on a volume targeted ventilation setting. Here again, if you remember the previous graphs, we are actually having a mid zone with pressure support plus CPAP. And on either side, we can have the typical graphics of SAME, of course, with the positive end expiratory pressure. So only the mid zone looks like CPAP plus pressure support. On both sides, it is SAME with PEEP. The idea here is once you give a pressure support, you take a bit of work of breathing from the patient so that patient will not get exhausted. So the volume may not be guaranteed, but definitely a good portion of the work of breathing is taken up by your machine. So here we'll quickly go through some scenarios. Here you can see the pressure tracing and the flow. So what you are observing is ineffective triggering, because the arrow mark, if you can find, that is not getting translated into a breath cycle. Here what you see is a different kind of scenario, which is called double triggering. Patient inspiration continues after the ventilator inspiration and triggers another breath immediately after the inspiration. So it happens in high ventilatory demand, like in ARDS patient, or when you have inappropriate settings like low tidal volume or short inspiratory time or high expiratory trigger sensitivity. So this is how your screen will look like with the double triggering. So soon after one inspiration cycle, another inspiration happens. This has already been discussed, the active exhalation part, and flow asynchrony during inhalation can be seen as a deflection in the positive side, and when it happens during exhalation, it can be seen as a dent in the exhalation tracing. Okay, this is a scenario where a 20-year-old female on ventilation with the bronchial asthma exacerbation. So the resident notes that the tidal volume is not getting delivered all of a sudden, and the alarm keeps beeping with the low tidal volume, 170 mLs and minute volume of 2.1 liters and all. The resident goes and increases the Pmax setting to 45 centimeters of water. And now the peak pressure is able to go up to 45 centimeters of water and show up a tidal volume of 362. And the resident also increased IE ratio to 1:3. Would you agree to this management, and what is the logic? I think this is what you were trying to explain, Dr. Anoop, the change in Pmax.
Yeah, this is the one which we explained last time. See, like suppose here the tidal volume is kept at say 300 or 400, but the tidal volume delivered will be less. So this is the point where you have to look at the P max. If the P max is set low, definitely your P peak will be going high in the obstruction, and the machine will not be able to generate the tidal volume. The same thing will happen when there is an obstruction in the ET tube also. In same scenario can happen. So don't think that it's always a bronchospasm. You assess the patient. If there is an ET tube obstruction, there is no point in increasing the Pmax too much and increasing the tidal volume. You have to definitely change the tube and relieve the obstruction. If it is because of the airway obstruction, and even after like taking out the secretions, even after appropriate bronchodilator therapy, that is a situation where we have to keep the Pmax high. And whether this is advisable, Dr. Saneesh will explain.
Okay. So
what the resident has done is correct or not.
Sorry. During volume control ventilation, if your pressure peak touches your Pmax, then check the P plateau values. If plateau values are acceptable, that means what you are encountering is an increased airway resistance. There you can contemplate going up on pressure limit or Pmax on your ventilator. Remember, before that, you should be knowing that your plateau pressures are okay. That means it's not something to do with the lung compliance per se. It's a resistance issue. So now, another way of handling this increased airway resistance is giving adequate expiratory time. So this is the graph we have explained what is peak inspiratory pressure. And this is the resistive pressure to overcome the airway resistance, and the plateau pressure reflects the elastic pressure, and the Pmax is usually by default set at 40. In our anesthesia machines, some of the machines we mention it as a pressure limit also. So increase the pressure limit, even if peak pressure goes to 45, 50, nothing happens as long as the plateau pressures are within normal limit. It doesn't mean that you allow peak pressure to be at 45 or 50. You take measures, troubleshoot, find out where exactly is the problem, give bronchodilator, or pull out your endobronchial intubated tube to put in proper position and bring it down at the earliest. So until then, this is how you identify. So the flow versus time, what happens in obstructive expiratory flow limitation, the peak expiratory flow comes down and it takes long time for the exhalation to complete. So whatever you have pushed in should come out. So you give more of expiratory time. So this is what is called air trapping that we have discussed already. And how to set the expiratory time. There is something called time constant. Time constant is the time required for inflation up to 63% of the final volume. Or if you are on a downslope, deflation by 63%, it is the product of resistance and compliance. Most of the or all of the modern ventilators will provide you values with of resistance and compliance. You multiply these two values and find the time constant, and at least try to give expiratory time 3 times the time constant so as to allow enough time for exhalation. So here you can see once you allow more expiratory time, this tracing is able to touch the baseline, or rather whatever we have pushed in is almost coming out completely. There is no hyperinflation happening and air trapping happening, no autopy getting generated. So,
and if you take a look at our lungs, you can see that there's a lot of atelectasis in the lungs. The darker areas are atelectatic and the lighter color is aerated. So what we're going to do is...
So this is just to impress upon you how a pressure volume loop helps you to understand what is happening inside. Okay, here you can see a lung with a lot of atelectasis, and some units are recruited, of course, but de-recruited units are far more. So what is happening is to generate a decent tidal volume of around, say in this graph, you can see around 400, something around 400. The pressure generated is something close to 25 or something. So here they are doing a recruitment. Okay. How to do recruitment properly, Dr. Anoop will say. Here you can see the airway pressure has gone up temporarily. And then after the recruitment, they'll resume ventilation. Many of the de-recruited lung units are now recruited. And now the pressure required to attain the same tidal volume is far less. That means lung in toto has become more compliant, which is again visible in your pressure volume loop. Okay. Here you can see with the pressure coming down to around 17 to 18, tidal volume achieved is something close to 500. You know, we would like to comment on this lung recruitment maneuvers for the benefit of the residents.
The recruitment again, if you go with evidences, the evidence for recruitment is very weak nowadays, but there are some particular situations where the lungs are really recruitable. So there are many ways by which you can do the recruitment. The usual way is by the incremental PEEP method. The PEEP you gradually increase, then you attain a level, then gradually you reduce and see whether the compliance is improving or at what level you are getting the best compliance. Or we have a constant inflation method where you keep a constant pressure of say 40 pressure control for 40 seconds, then see whether the compliance is improving. Then you gradually reduce the PEEP and keep it at an optimal PEEP. So there are different ways by which you can do that, and even the APRV mode, etc., you can use and you can do the recruitment. But see how you see whether the lungs are recruitable or not. While explaining the PV loop also, we have already told that. So see that this inspiratory limb here and the inspiration or the inflation limb here. So this is a lung which is really recruitable, and again the compliance will improve. Compliance improve means the curve will shift towards the this side, okay, towards the x-axis.
And your mouse pointer is not visible now.
I'm pointing anyway.
Okay. So on the left side, there is left side graph, there is low potential for lung recruitment, and the right side one, there is high potential for lung recruitment. We'll go back one slide. Yeah.
Okay, so if it is like this, the second part, then definitely it is a recruitable lung, and definitely you can apply more PEEP and see whether the compliance is improving or not. So these are the two types of lung, and these are the two different types of PV loops as well. And the PV loop using titration depends on the different the protocols, where you can set in the machine itself with what PEEP it has to start and where it has to end. And then again, how we have to do the decremental PEEP titration also.
Okay, so whenever you happen to be by the side of the patient on mechanical ventilation and your ventilator gives an alarm sound like this. Okay, you can see the tidal volume is low. This is a pressure control ventilation. So there is no question of pressure going up. Respiratory rate is high. When you get a high priority alarm like this, never switch off the alarms. Try to go near the patient, catch all the clinical indicators, troubleshoot, find out what exactly is happening with the patient, whether the patient needs to be passive, whether the patient has a high airway resistance issue, or suddenly patient developed a low compliance, like say for example, a sudden onset of pneumothorax, or lung compliance worsening over a period of minutes to hours. Identify from these graphics, from the values, the monitored values, look at the patient, look at your hemodynamic monitor, you get a holistic view, and with a positive intent, try to do the troubleshooting with the best of your knowledge and ability. And in acute care settings, if you find your knowledge, skill, or ability is a limiting step, never hesitate to take help. Call for help, do the needful, because patient may not get a second chance in acute care setting. That is the importance of knowing scalars and loops, or becoming more familiar with the rapid clues our modern ventilators give you on the bedside scenario. Pick up the clues, be familiar with the solutions, get a handful of solutions with you when you go to the bedside, and interpret scalars and loops more meaningfully. Every day is a learning opportunity. Make use of it. Wish you good luck. We'll stop the presentation. Thanks very much for patient listening. It's over to Dr. Vijish.
Thank you, Dr. Saneesh and Dr. Anoop, for that exhaustive presentation on the scalars and loops. You had initially started off with the basics of scalars and loops, later integrated it with the modes of ventilation, and finally put it all together with those two wonderful scenarios. It was a great learning experience, and it was wonderfully done.
No questions in the chat box.
What's the significance of the upper inflection point?
I've already answered during that session. The previously, like whether to use an upper inflection point or a lower inflection point, or the average between the two for the PEEP titration was a debate. But later on, like nowadays we are not looking at upper or lower inflection point. We have to do the PEEP titration, looking at the PV loop at different points. Then, like by taking an average of, or by assessing the compliance, looking at those loops, like how the loops are getting deflected towards the better compliance side, we have to decide on the PEEP. So the PEEP, don't think that by looking at that graph, saying an upper inflection point and a lower inflection point at a given PEEP, you cannot determine an optimum PEEP with that. You need multiple PEEP and multiple PV loops, then only you will be able to determine which PEEP is giving a better recruitment.
Basically, these are guiding posts, not the deciding factors. And there is
there's a question in the chat box regarding double triggering.
Yeah, we have already explained, like after one inspiratory cycle is over, patient is again triggering one more breath cycle, which happens when the inspiratory flow is inadequate for the patient. So what we can do is either take increase the inspiratory flow, or give more inspiratory time, so that basically ventilator provides flow into time is volume. So sometimes when you cramp down the inspiratory time, this happens. So the message patient is trying to give you is, give me some more inspiratory time. So that way we can avoid the double triggering.
Anything regarding this driving pressure? Could you throw some light on?
Anoop, your favorite topic.
Yeah, actually, this was getting delayed. That is why that recruitment in detail and the driving pressure, that those are the two areas which we didn't touch much. So ideally, like from the compliance or the better oxygenation, nowadays we are looking more on the driving pressure. Driving pressure is nothing but the difference between the plateau pressure and the PEEP what you are keeping. So, and we always try to keep a plateau pressure somewhere around 15. There are like different trials looking at 15 to 17, but an average of driving pressure 15, we do that. So how this was done? We have the previous the ARSNet protocol looking at different tidal volumes, and from where we concluded that the low tidal volume ventilation is having a survival benefit. So by looking at the plotting at those all graphs, it has seen that it is not depending on the high pressure or the plateau pressure. It is actually depending on the driving pressure. Even if you keep a high PEEP or a lower PEEP, if the driving pressure is maintained at the given 15, the survival benefit will be better. So while so ideally, what should happen? Your driving pressure should come down once you give a adequate PEEP for a given tidal volume. So that is one method of looking at the PEEP. So always see that the difference between the plateau pressure and the PEEP pressure is the driving pressure, and that has to be maintained at 15 rather than looking at plateau pressure and keeping below 30. So that from the concept of like artset ventilation, where looking at plateau and keeping it 30, we have moved down to the driving pressure and keeping it at around 15.
There's another question in the chat box. Can we still use SIMV mode for weaning?
That was explained in detail, that SIMV mode is already an outdated mode. I don't think in the present ICU ventilation scenarios, SIMV mode has any role. Even when you use an anesthesia ventilator for like extubation, I don't think SIMV has any role like in the advanced the anesthesia ventilators. You can very well put on to the assist control mode, adjust the trigger, then put on a CPAP pressure support mode, reduce the pressure support, and if it is adequate, you can very well extubate the patient. The same thing is applicable in the ICU also. You put the patient on CPAP and pressure support. Between CPAP pressure support and the TP's trial, still it is debatable. But once you ventilate a patient with a proper PEEP and all, nowadays we don't usually keep the patient on TPs and de-recruit the leg, rather than we keep a patient on a minimal pressure support and PEEP. Then from where we extubate, and nowadays most of the time we keep the patient on a NIV or iFlow nasal oxygen even after extubation. So in that scenario, definitely the TP's trial is also not really justifiable, even though it is not an evidence-based comment.
Fine. We've had a very hectic session today, and thank you so much, Dr. Vijish, Dr. Anoop, and Saneesh. It was done so very well and in such an elaborate way, and truly, not only the students, but we all benefited. The lovely graphics that were shown, the colored with all different scenarios. Really, it was very, very of a very high quality and great standard. Thank you so much, Dr. Anoop, Vijish, and Dr. Saneesh. And we look forward to the next week's program. And of course, we look forward to seeing you all again. Possibly, maybe the topics like recruitment that have been left out, we could cover that in some other webinar in the following weeks. That will be excellent. And thank you very much. Thank you, Dr. Radhakrishnan, Dr. Baljeet, I can see, Dr. Murlidhar, and of course, all the other viewers. And Farhaz, thanks a lot. See you all next Wednesday at the same time, 7 o'clock, with our next topic.